and welcome to the GHAPP MASLD Community Network website. My name is Maly Tiev, and I am a nurse practitioner currently working with NYU Langone Health in New York. I'm here to discuss demystifying liver function tests, or LFTs. So thanks for joining in. ALT and AST are liver enzymes, and they are markers for inflammation. However, you can have inflammation in the liver without elevation in liver enzymes. Normal values varies according to different labs, and most lab range are higher than what should be considered normal. So the true normal, according to American Association for the Study of Liver Disease, or AASLD guideline for the ALT, is 29 to 33 in male and 19 to 25 for females. The AASLD recommend that anyone with persistent elevation of ALT and AST above 30 for men or 19 for women for more than 6 months should trigger further evaluation for MASH, including exclusion of other liver disease, and do a non-invasive risk stratification for advanced fibrosis. Many patients with MASH actually have asymptomatic, and they can also have normal liver enzymes. So the AASLD and the American Diabetes Association also recommend screening for MASH in patients with risk factors such as obesity, BMI greater than 30, anyone with type 2 diabetes, and those with metabolic syndrome. In MASH, they typically have a mild ALT greater than AST, and the pattern is usually both values are less than 5 times the upper limit of normal. So if someone have, for instance, ALT greater than 200, you want to start thinking of other potential causes like alcohol, viral hepatitis, autoimmune hepatitis, or drug-induced injury. Another important thing to keep in mind is that the degree of enzymes elevation do not correlate with fibrosis severity. In fact, those with cirrhosis tend to have normal liver enzymes. Now, let's look beyond ALT and AST. Those liver enzymes are just part of the picture. What about other LFTs components? What you want to also look at is alkaline phosphatase. Alkaline phosphatase is usually normal or mildly elevated in MASH. Significant elevation suggests cholestatic or biliary disease like PBC, PSC, or infiltrated processes. So if you see high alkaline phosphatase, you want to look for other causes. Next, you want to look at GGT. Often, GGT is elevated in MASH. It is also a marker of oxidative stress and insulin resistance. GGT can also help confirm hepatic origin for an elevated alkaline phosphatase. Total bilirubin and direct bilirubin typically is normal in MASH unless there's progression to cirrhosis. So if you see elevation, especially in the direct bilirubin, this may indicate advanced fibrosis, cirrhosis, or even biliary obstruction. You also want to look at albumin and prothrombin time. Both of these markers are hepatic synthetic function. In MASH, these are generally preserved until advanced fibrosis or cirrhosis develop. Platelets, in my opinion, is one of the most important tests to look at. Typically, platelets are normal in MASH. If the platelet is less than 150,000, you want to start thinking of cirrhosis unless proven otherwise. LFT abnormalities can have many causes. So how do we separate MASH from others? As I mentioned earlier, typically in MASH, you normally see mild to moderate elevation in ALT and AST, usually less than 5 times the upper limit of normal. So if your ALT is greater than 200, something else is going on here. You want to rule out other causes. In alcohol, AST is usually greater than ALT in a 2-to-1 ratio. Plus your GGT would be elevated as well. In viral hepatitis, the liver enzymes can be very high in acute phase. Once the patient becomes chronic, for instance, like in chronic hepatitis B, the liver enzymes can be normal for many years. With chronic hepatitis C, the enzymes can be mildly elevated or moderately elevated. So The most important thing to remember is you want to screen all patients for hepatitis B and C. As far as medication go, you want to look for drug-induced liver injury, such as from statin, NSAID, antibiotic, and especially supplement. You want to ask the patient specifically what over-the-counter supplements or herbal products they are taking. Sometimes patients do not disclose this unless you ask them. Remember, MASH is a diagnosis of exclusion after ruling out other causes with target history, labs, and imaging evaluation. Liver biopsy is reserved for cases where diagnosis remain uncertain. Now, let's talk about monitoring. What is the role of serial LFTs monitoring in managing patients with MASH undergoing lifestyle or pharmacologic intervention? What changes signify treatment response or disease progressions? So serial monitoring of LFTs like ALT, AST, alkaline phosphatase, GGT, bilirubin, albumin, platelets, and prothrombin time plays a central role in the management of patients with MASH undergoing lifestyle modification or pharmacological intervention. I like to repeat LFTs in my patient every 3 to 6 months after initiating lifestyle changes or drug therapy. If you see a reduction in ALT of at least 30% for baseline or normalization of ALT, this is associated with histological improvement and resolution of MASH. Stable or improvement in albumin or INR during therapy indicates preserved hepatic synthetic functions and are reassuring during therapy. However, you see a rising bilirubin or declining albumin, rising INR or platelet decreasing below 150,000. This may signal progression to advanced fibrosis or cirrhosis. In patients with cirrhosis, the AST may become higher than the ALT due to hepatocyte damage and reduction in ALT production. So AST to ALT ratio greater than 1 can suggest progression towards cirrhosis. So remember, recognizing subtle LFTs abnormalities in the right clinical content can catch MASH early before fibrosis develops. ALT and AST are your first clues, but interpreting the full panel and ruling out other causes is critical. Serial LFTs monitoring helps you track treatment success. And with that, I'd like to thank you for listening. If you have any questions, please reach out. I'd love to hear from you.